All right, folks, I think it's about time to get started. I'm sure some people will join in as we go, but I want to make sure our speakers have plenty of time to present their topic, which I think should be of interest. My name is Harry Hockheiser. I'm the director of the MIDAS Coordination Center, and it's my pleasure to welcome you to our monthly webinar at this special time today. Today, we've got a team presentation by two folks from the RAND Corporation. I realize I forgot to get the pronunciation of the names in advance, so I'm going to apologize if I get anything wrong. But we have Raffaele Vardavas, who's a mathematician at RAND, whose interest lies in applying methods from statistical physics to models of complex social systems and policy, where he works specifically on the modeling the spread of infectious disease and behavioral contagions in social systems using both population-based and agent-based models. Raffaele is a PhD in physics from Imperial College in London and was also a postdoc at UCLA in applied math and later in the biomathematics departments. Along with Raffaele, we have Pedro Nascimento de Lima, who's an assistant policy researcher at RAND, a PhD candidate at the Pardee RAND Graduate School, and a visiting student at Argonne National Lab. His research interests are the health policy applications of decision-making under uncertainty methods. He's passionate about tackling complex and deeply uncertain policy questions with modeling and high-performance computing. So Raffaele and Pedro, really appreciate you taking the time to speak with us, and I'll let you take it away.
Okay, thanks, Harry. Thanks, Stephanie, Jess, for hosting this webinar. So I will start with the introduction, and then Raf will take it away at some point in the talk. So let's get started. So today, this is what we will cover. So before we get into modeling infectious behaviors or behaviors in infectious disease models, we want to make sure we know and understand why we're doing it, why we think it's important, and why we think you should think that's important. Of course, that's a self-selected audience, so you probably already like the idea, but either way, it's important to think about why we're doing this. Also, we will talk about what we have done so far with 3 examples that incorporated behavioral in some way using different approaches, then where we are headed and how do you fit in what we're doing. So we are collecting new data now. We'll be doing so for the next several years. So it will be really useful to get feedback from this audience and this community as well. So why should we care about modeling infectious behaviors? So in this essay called Modeling Infectious Behaviors, Raf, I, and others argue that accounting for behavioral mechanisms and behavioral adaptation in COVID models is important, and we lay out some steps that can be taken to do that. This talk builds on that essay and also includes some results from other papers. So before we start talking about behavior, let's be clear about which behaviors do we care about. So here we are talking about essentially 4 classes or types of behaviors. One is mixing behaviors, right? The thing that changes the transmission equation in your models. Second, treatment behaviors, right? The fact that some people might choose different types of treatment. Then vaccination behaviors, the fact that people might decide to vaccinate or not, or postpone vaccination. And lastly, influence, right? So here we're really talking about behavior transmission, the fact that people do things because others are also doing those things. Now, why do we care about this? Well, behaviors are influenced, it can be influenced and constrained by policy and politics, right? So all the policies we used in the COVID-19 pandemic, including social distancing, mask wearing mandates, stay-at-home orders, and so on and so forth, change mixing behaviors. And they may have changed those behaviors beyond just the duration of the policy as well, right? Our post-pandemic new normal doesn't look exactly like our pre-pandemic status. Second, vaccination mandates, vaccine availability, all these policies change or influence vaccination behaviors, treatment availability, and what I call political sponsorship of specific drugs also change treatment behaviors. And we've seen that in Brazil and here in the United States as well, and in other places. And this 4-point maybe the most important because we know that misinformation, mainstream media, social media influence the aspect of behavior transmission. So the reason why people are doing what they're doing is also influenced by dynamics of misinformation or information in this interconnected world. And when we pose our models without accounting for these mechanisms, we may be betrayed by our assumptions. So the question is, can we pose models that can shed light into these policy-relevant behavioral mechanisms? And can these models be any better than the ones we have? Currently, if behaviors are heterogeneous but static, they can be and have been addressed to a certain extent. For example, if you have a COVID-19 model, you probably characterize the heterogeneity of contacts in a network with mixing matrices, right? Everyone has been doing this. Then you can fit a time-varying transmission parameter, scale that matrix, and you're kind of accounting for behavior. And that, of course, takes assumptions, but you're accounting for that by through your inference approach. And similarly, vaccination behaviors also can be accounted for if we account for different population strata with different likelihoods of seeking vaccination. So that can be done, and it's not so hard, and it has been done in basically every model. However, here we are talking about behaviors that are not static, right? So if you fit your model to data, you're basically making three kinds of assumptions. One is that behavior is persistent. So people will behave in the future as they behaved in the past. And that's an assumption that we make. Second is behavior is not endogenous, right? It's not endogenous to the model. So people are not adjusting their behaviors, even in information. So, being vaccinated will not lead you to meet on Thanksgiving if you just have a static behavior model. Also, people don't wear masks when cases go up as they take the umbrella when it's raining. So these assumptions may contradict some of our intuition and knowledge about how people think. And lastly, the static behavioral assumption also implies that behaviors are not infectious, right? There's no network effect. People don't do things just because others are doing those things. These assumptions may hold when people don't care about infectious diseases, right? And that's why these models can work when there is society is functioning and people are not thinking necessarily about infectious diseases. But these assumptions may fail us precisely when the world is watching our models, because that's when people are making these decisions more in thinking about those decisions and talking about those decisions. So that's when behavioral models might be useful. So it can be very challenging to depart from these assumptions, right? So if behavior is not persistent, then how is it changing? How can we possibly know how behavior will change in the future? If behavior is not endogenous, then, well, what is driving it? It is even in the model, right? We have a set of variables in the model, state variables, that don't include important things that exist in the real world, like the political system or social media. And these things might drive behavior very much. If behaviors are not infectious, then how does it spread? The spread of behavior can be more stochastic and unpredictable than disease itself. So it can be very hard to do that rigorously. So the question is, can we formulate credible behavioral models that can align with existing evidence and data, aligned with our knowledge about how people think? And would these models be any useful or better than the ones we have? So this is not a talk about definitive solutions. As you can imagine, these are hard questions. We don't claim to offer definitive answers to those questions, but we did make some efforts to account for some behavioral factors in our work. And particularly, we're interested in policy-relevant behaviors, right? So behavioral mechanisms, factors that could influence policy choices that would make us make a different decision. And we also have collected panel data on flu vaccination behavior for a few years, and we will continue doing that for flu and COVID, so we can learn something about how people changed their behavior, their vaccination behaviors after the pandemic. And so if you're interested in this source of data, then now is a great time for you to see our work and be aware of what we're doing and maybe even collaborate with us. So I also want to say that we are not the first to care about modeling behaviors. This is not a necessarily new stream of work. There is a growing literature using game theory, and it uses different types of behavioral models. So we're kind of building from that stream of work. Now, this table might be helpful for us to think about what are the characteristics of behavioral models, right? So you can think about modeling behaviors as either exogenous or endogenously, right? So exogenous behaviors can be specified through time-varying parameters. They can be driven by other variables that we see in the real world, like you can observe people wearing masks and then relate that to a transmissibility in your model, and then you can drive that with your model exogenously. And that's, I think, what has been done most often. There's also the possibility to model behaviors endogenously. And so the behaviors emerge as a response to other model inputs, sometimes in nonlinear ways. That can be hard as well to do, of course. Then if you're modeling behaviors endogenously, then you can have different types of reasoning assumptions, right? You can have a deductive framework. For example, utility maximization from microeconomics is the key example, right? People are maximizing utility. Rational, people are rational and they are making these calculations before making decisions. There's also this inductive reasoning approach. People are using heuristics. They have bounded rationality, so they use the information they have and adjust and adapt over time. That also has been done. It's possible to do. Then there's types of behaviors. Well, there are also sorts of things we can model and put in our models. And the interesting thing that it's probably not in our model and matters is rumor spreading and the political dynamics that we go through. Also, there's the time frame, like, what is the decision that people are making? Is it a one-time decision? Is it a repeated decision? And that influences how you model this. And also information availability, right? What is the type of information that people use to make those decisions? And you can combine these features or these characteristics, and you can probably see them in every model you look at. So, okay, so now we turn to what we have done so far. So I'll give a brief explanation about the Reopening California paper, why we consider behavioral uncertainty in that paper, but that is kind of using the exogenous approach, not that interesting. Then we will go to the should we suppress or mitigate the next pandemic, which takes the deductive reasoning approach. So imagining that if people were really rational and were making rational decisions, weighting costs and benefits of their decisions, how would they behave? And that's how we proceed with that paper. And then lastly, there is a set of inductive reasoning models, and that's where Raf will pick up. And then, we'll discuss where we had. So reopening under uncertainty. So you may not be aware, but we at RAND created this tool very early in the pandemic, within I think 6 weeks, to integrate an economic model and an epidemiological model, and to give people a sense of how the pandemic might respond given different levels of interventions. And we built on this work, and then we later in the pandemic, when we were more certain that we would get a vaccine, then we asked how California and other jurisdictions should approach reopening in the wake of vaccination. So this was late 2020. We didn't even know if vaccines would work that well. There was a lot of uncertainties about new variant strains, and that wasn't even, people weren't even talking about that necessarily at that point in the mainstream. And so we set out to do this analysis to stress test reopening strategies and long-term reopening strategies, right? How do you manage reopening plans over time, over the next year, given these uncertainties? And in that work, we used the robust decision-making approach. I won't talk too much about it. I will say that we'll have another event that will just talk about uncertainty, and you're invited to join that. You can find that in the MIDAS website as well. So we use this approach, robust decision-making approach, and the idea is that you take a decision that you want to make. You think about the strategies you can use to manage this evolving dynamic system, and then you stress test these dynamic strategies. And you use your models not to predict the future, because, well, if you could predict, then you would just do that, right? But you use your model to stress test the strategies you have and to learn the vulnerability of those strategies, and also to understand the trade-offs between them. And what we did, and in the first step in this robust decision-making framework, is a decision framing exercise, which is really important if we want to include behavior, because there are so many behaviors that may matter, right? And we need a step in the decision analytic approach where we think about what are the behaviors that really can present challenges to a specific strategy. So for example, for the reopening plans, how we were scaling them down, we listed 6 uncertainties that in retrospect seem still quite important, right? Vaccine efficacy to prevent transmission, loss of immunity. And then there were some behavioral aspects that we included in this analysis. The behavioral response to vaccination, meaning how would people react or increase transmissibility or transmission after they got their vaccine? So would they get the vaccine and go, and hug their family, or would they just, not increase their transmission? So the standard assumption will be, well, they do nothing. They just get the vaccine and that's it. But we thought, well, it's probably likely that they're getting the vaccine because they want to mix more. So that's an important behavioral response that we wanted to include. There's also the willingness to vaccinate by different population strata. Turns out to be important. And the actual vaccination rate, right, depending the rate at which people seek vaccination. So this was a case where we incorporated some behavioral uncertainties into our analysis. I will not spend a lot of time talking about this because these are relatively simple, and you can look at how we modeled that in our paper as well. Yes, so that's this. So now I will leave it to Raf to talk about the deductive reasoning approaches and the inductive reasoning approaches.
Thank you, Pedro. Okay, so I'm going to talk about, first of all, the deductive reasoning approach and a simple example that we've recently worked on. There's a lot of literature starting from, well, even before, but Chris Bauk really did a lot of the work on this, and actually is also one of the reasons I've been working on infectious disease models, looking at his first papers on game theoretical models and behavior and deductive reasoning games applied to infectious diseases. So if we go to the next slide. Okay, so we're looking, in this case, we're considering a population of hyperrational agents, and they all have a same perceived final time horizon of when an epidemic might, end, let's say. So when perhaps herd immunity might be reached or a vaccine would be available, and they have to make decisions as to whether, adopt a strategy or what social distancing do they apply, and they, would they collectively, let's say, mitigate the epidemic or do a suppression strategy, and this depends very much on the time horizons that they're all collectively thinking. So there's a bit many assumptions here, simplifying assumptions, but what I'm trying to show here is, the kind of things that we could see also then when we go to more sophisticated and more detailed heterogeneities. But bear with me with the simplicity first of this. And so we're considering exactly these hyper-rational agents, and they all have this, they share the same cost of social distancing. And exactly, they could choose to mitigate the epidemic, and roughly that means the R0 will be reduced, but not to the point that they have to sacrifice mixing and the R0 is still gonna be above 1. But if the cost of social distancing is not going to be as high, and there's certain conditions, they might turn to a suppression strategy shown here, where really the number of infected, the I in the left-hand panel, I, is going to be pretty small, and indeed early on the R0, which is, I'm calling here RD, the basic reproductive number, RD, because it's dynamic in the sense that they're changing that in the sense that it will depend on the transmissibility beta, but which is a function of time, which is reflecting the rate at which they're going to be mixing. And this R tau, which is going to basically be the effective reproductive rate. So yeah, next slide. So I'm going to go through the setup of the math. So okay, so we have RD, which is basically in a simple SIR model, the transmissibility beta times, well, usually divided by gamma, but here I'm multiplying by the time, but it's 1 over gamma, which is the time, the typical time of going from infectious to recovered, and the rate, the fraction, the proportion of beta t to beta zero would be the transmissibility rate in absence of any measures. It's basically the same as RD of t divided by R tau. And of course, we have that effective reproductive rate, which is just S, the number of susceptibles times the that dynamic reproductive rate. Then, in the pink box, purple box, sorry, that is the SIR model. It's written in this, we've changed without basically the units, and we transformed it so that it's all in terms of RD. Okay, and so if we're considering the social cost of the total social cost of society, that's a function H, which is a function of the number of susceptibles, infected, and RD. So the first term there, RD times SI, that is just the total incidence into I. So we're saying that that's the cost of catching to society of the number of people contracting. If we're talking about COVID, then the second term would be the cost of the social distancing. So we have this unitless parameter C, which is basically the proportion, small c at the top, which is this proportion of a big C, which is the rate of the cost of social distancing per unit time. We're multiplying that by tau, the infectious period, and divide by d by the cost, the perceived cost of the infection. So this function g has certain properties that we can assume, and this is a functional form that we considered, but it could be various functional forms. But the idea is if x is 1, meaning the proportion of RD, the dynamic reproductive number, to the basic reproductive number, if that's 1, so basically there's no social distancing. We're just allowing the epidemic to run as is, and hence at x equals 1, the function that cost is going to be 0. Moreover, the gradient is going to be 0 as well, because any changes, small changes to to the reproductive rate or the measures will have minimal cost implications. But of course, as you really start decreasing the RD, then it's going, that cost is going to be, exponentially increasing. So that's the functional form. We can consider other functional forms, but we think that the conclusions are kind of robust as long as these are the factors which go in. Okay, so we have that cost for expression H, and that goes in what we can call a Lagrangian, which we can find the extreme of it by considering also the constraints. The constraints are basically described by the dynamics, and the dynamics is the SIR model. So we have two Lagrange multipliers, lambda S and lambda I, multiplying the SIR model. Of course, the two equations. The third, of course, is contained due to the conservation of people. You put that into the standard Euler Lagrange equation, you get basically and YS here are SR, SI, and RD, and you can do that and get the equations describing the dynamics within the boundaries, and the boundaries are, of course, at time equals 0 and our fixed time, final time, which is shared by the whole population. We also have an initial number of people infected, I0, an initial condition. We don't know initially the constraint values for lambda S and lambda I, but we do know that at the final time, those constraints go to 0 there. So because that's the end of the dynamics. And you can run numerical methods. The most basic of these boundary value problems is the shooting method, but there's others that we've used to find the dynamics. So that describes the setup. And so the inputs that we considered was an R0 of 1.5, not too big. I0, 10 to the minus 4 initial number of infectious, and we've varied these, but I'm going to just show the set of numbers, results. Tau, which is that scaled time of I to R. In this new settings, we call it 1, but it represents a time scale of 14 days, going from infected to recovered. And we considered different time horizons, which go from 4 to 60 months, but in this new scale is 8 to 128. This C is the duration of a threshold duration of distancing, and it goes from 1 month to 2 years. So basically, for example, if C is equal to 0.4, that we were saying that the cost of social distancing for a month is equal to 40% of the cost of contracting the disease. That's what's the interpretation there, and the same thing if for the upper version. So the cost of social distancing for 2 years is equal to 2.5 times 10 to the minus 2 of the cost of contracting the disease. That's in the lower value of C. So when the cost of looking at the results, when the cost of social distancing is small, well, we see and the time scale is small. What we see is that even initially we see that they're all the dynamics is all kind of in agreement, and the R0 is always larger than 1, and this is because the total, the final epidemic size, although it could increase after, but people are just considering in this fixed time horizon of 8 or 16, and the number of people who are going to contract the disease in that short time scale is small, so they're not too bothered about it, and R0 could be quite big. The number of people, the R0, the RD could be larger than 1, and remain larger than 1. But as you increase the time time scale, then we get a new settings and a new scenario where for the low costs, you have a situation that they'll change low cost, low C, meaning low cost of social distancing. They will end up doing a suppression strategy for quite some time before, allowing the epidemic to take over, because they know that soon there will be a vaccine or they've reached herd immunity. So that's the interpretation there. So next slide.
Yeah, I just had here, Raf, that even in the what you could call a mitigation strategy, people do kind of a lockdown here, right? I mean, people don't just go about their lives and do nothing about the pandemic. Even when the cost is high, they do an initial response, even though later they relax. And we think that they're doing this because they want to avoid they want to prevent the pandemic from getting out of control completely. So they need some response. There's never a case where you simply do nothing about it, right?
Right. Okay. Next slide. So, this just shows the abrupt transition, the abrupt point there in this plot between the final time horizon and the cost of social distancing, and for very short time horizons and low cost of social distancing, then you have a suppression strategy. If it's long time or high C, then you probably would they would go for that mitigation, and exactly it's an abrupt change. So okay, that ends. We can move to the next slide. That's basically describes the deductive approach. So going to the inductive approach, this is where individuals are considering past experiences. So and they might not have full information, but they could be a homogeneous population, but they might, they're doing a repeated choice. And here, of course, it's we're considering influenza, where people of course have to make and let's consider the pre-pandemic scenario where people have to make decisions of vaccination on a repeated yearly. So this is an old work of 2007, where we did a very, very simple inductive reasoning game, no networks or anything. There was just a homogeneous population where in terms of behaviors and no histories, etc. But what we see here is that they make, they go through a decision outcome and evaluation process. The decision is whether to vaccinate or not. And they have these, perhaps an initial probabilities W. And, if they go down through the low branch and they did not vaccinate, then they will evaluate their outcome on whether they caught the infection or not. And whether they caught the infection or not, it can be done through a simple SIR model, and they update their propensity to vaccinate based on this V parameter, which is considering basically a tally of the times of whether it was important to vaccinate based on the outcomes of that season. And so the one there, which I'll call delta eventually, if it's not just 1 or 0, but it's basically a tally of the times that vaccination was evaluated to be necessary. Now we have an exponential weighted moving average situation where we're basically allowing individuals to exponentially put less weight on very long past outcomes compared to the most recent ones. And so they go through this process of evaluating. Now, going through the upper branch of if they vaccinated, they would evaluate more on a global outcome, on the observation, perhaps through broadcast media, on whether or not there was an epidemic, and whether or not there was an epidemic can be evaluated based on whether the critical vaccination coverage was reached, as calculated as 1 minus 1 over R0 in a most simplest way. And the idea here is if you run the dynamics, you can actually see how this homogeneous population segregates into two groups. People who most often don't vaccinate and those who do. And this is a stationary situation, but there's a lot of dynamics at the micro level where people do change strategies. the interesting thing that we've shown here is that we wanted to also use this model to evaluate how a universal vaccine for influenza, which would promise to protect for multiple years, would do. And what we see is that there's a sweet spot which of 3 years, but that really depends on the memory parameter of how fast people forget past experiences. So if you can coordinate things with that memory parameter, the universal vaccines can have a big impact in terms of reducing the maximum prevalence. However, if the protection starts to increase, the duration of the protection increases to 5, 6, and more years, then what we can get is things which you actually make it even worse when you have situations where individuals are protected multiple years, then they become complacent and a big epidemic happens without, a particularly transmissible strain, etc. So that's a simple model of inductive reasoning. And just continue, if we can go to the next slide. So then starting in 2011, we started to say, well, okay, let's try to see these new, these behavioral models. And we ran a first survey about through the American Life Panel at RAND, about 2,000 respondents. Sorry, in this first surveys, it was about 600 or so respondents to see how people make the decisions to vaccinate. And it was exactly a fall survey and then followed by a spring survey to see the outcomes. So we asked, whether their propensity to vaccinate, and that's the x-axis here. And then the color of yes or no was based on the spring survey and what actually happened. And you can see how this U-shaped distribution emerged. But doing a Bayesian logistic regression analysis, what emerged was our simple model was quite accurate in the sense of how people make their posterior probabilities to vaccinate. For example, if they vaccinated and they caught influenza, it's true that they would continue to they would want to vaccinate. If they vaccinated and they did not catch influenza, then again they would continue to there's a high chance that they will continue to vaccinate. However, no vaccination and an infection in our simple model assumed a high probability of vaccinating. Here instead it's a moderate increase, and no vaccination and no infected, they still would tend to not vaccinate. So next slide. So I'm not going to go, not all the information really appears to be shown here. There's more details, but hopefully that will appear in the online version. But anyway, the whole point of this is I'm not going to make a big, and this is unpublished work because I didn't feel that there was as much to draw upon. But there is one important thing to draw upon in this. This is, we basically considered different assumptions of behavioral models. So we had the original one, which we had, and then we have other behavioral models which put more emphasis on different types of information, including social network influences. And then we have one which was informed by the behavioral from the survey, which is called the survey-based behavioral model, SBBM. And what we see is we looked at different network structures, Erdos, Rennie, Barabasi, Small World, and an empirical one, and with a vaccine efficacy of 70%. And we considered, there's two cases, if there's people randomly vaccinate and then people target vaccinate, these are the lines for showing in the plots of the proportion infected to the proportion vaccinated. And consider, keep in mind that there's vaccine efficacy is 70%. So unfortunately, we don't see the points here. It's only showing the distributions. But the point really is that there's a strong interplay between the network type, the behavioral model, and of course the transmission dynamics. And for example, you can have a situation where the survey-based behavioral model shows that people vaccinate more. However, they do it in a way that is closer to a more of a random vaccination. Instead, if people are doing more of let's say, the free riding or observation of others in the network vaccinating and trying to take advantage of the local herd immunity of people around them vaccinating, then they achieve a lower vaccination coverage. However, the proportion infected is more between the random and the more targeted vaccination. So they're doing it in a more efficient way. Indeed, if we looked at the clustering of people, and there's different on these networks, and you can see different measures of clusterings of people who vaccinate and don't vaccinate with these behavioral models. So that's the main message of this slide, is this strong interplay between networks and behavioral models. Okay, so now I think we can talk about where we're going and well, the flu paths. So if we can go to the next. So following from that work, we then started to do, and starting from 2016, a longitudinal study where we would ask 2,000 respondents about and follow them for 4 years, and so 8 waves, and for each wave we would have for each year we would have a pre-season and a post-season, a fall survey and a spring survey. In the fall survey, we'd ask questions about vaccination expectations, chances that they would vaccinate, whether they receive a recommendation, what are the risk perceptions of catching influenza without a vaccine, the chances of social distancing. There's many questions, but these are just a selection of things which I thought to illustrate here. The post season is whether they vaccinated, whether they caught the flu, how severe was it, did they get prescribed antivirals, what did they hear in the news about that flu season in terms of cases and vaccination rates potentially, and then we have also additional questions in terms of we wanted, of course, to know whether their employer required them to vaccinate. That's an important consideration. Also, the importance of various factors like cost, convenience, whether they like or dislike needles, or dislike needles, I guess, norms, how people generally vaccinate for influenza, and what are their how many do they consider catch influenza on a yearly basis, and their beliefs about influenza, how serious it is, and the efficacy of the vaccine, as well as then questions on social media. How often do they use social media, and how often do they see posts about vaccination appear on their feeds, and how often would they post their own feeds on vaccination? So those are the kind of questions, and you can see 2,000 respondents. At the end of the survey in 2020, spring 2020, it reduced to, so we had attrition, but we had quite a good a number of people staying. But by the way, the final survey in spring 2020 included questions of COVID, so we have some information on that. Next slide. The other important part of these surveys is we asked respondents to talk about their elicit up to 15 of their alters and what was their connection to these alters. Family ties, friends, co-workers, etc. Provide information about those demographic attributes, and also behavioral attributes such as whether they thought that they caught influenza, whether they thought or knew that they vaccinated, whether they think there are never sometimes always in terms of vaccination, and exactly the relationship to them, and so these create basically these egocentric networks of data of both in terms of local structures of these networks, as well as detailed information of as viewed by the respondent or the ego of what's happening locally in those social networks. Okay, next slide. So one of the things which is important here is how do you inform initial, more realistic agent-based models and the initial conditions or the synthetic network that you want to consider when the synthetic network can be used, of course, to provide to model preferential transmission paths, but as well as is the influence network in terms of how people are influenced and observe each other and communicate about behaviors. And so the assumption here is, you can have a large-scale social network data, such as the TransSim one, the one produced by the team by Madhav Marathi, when he was at the time Virginia Tech, and then Network Dynamics Social Systems Laboratory, I think that's what it is, and NDSSL. So that's a network, large-scale network of Portland, Oregon. I think it has about 1.4 million nodes, individuals, and 20 million edges. And so you have, and then you have these egocentric data sets. And the idea is, how do you merge these two data sets to create an ensemble of true graphs, which are unobserved, which has all the structure, let's say, of the large-scale network, but as well as all the features and behavioral attributes coming from the egocentric data. We've looked at different methods for doing the matching, simple matching methods, exponential random graphs, and most recently convolutional neural networks. And we have a working paper listed at the bottom there. So this is an important aspect of creating these initial conditions. And next slide. Okay. We've also then, made our used the data to construct this adaptive behavioral model, which considers, at the adaptation process of how people are consider personal evaluations versus social network influences versus mainstream media, and there's still this update of an exponential weighted moving average approach shown in the middle box at the top here. Yes, that's still present there, but that delta is no longer just 0 or 1 like in that simple model, but it comes from the survey. But at the same time, we also want to know they weigh adaptive components, but people, of course, also consider recommendations by the doctor or social or there's information from biological attitudes and social factors. So next slide. This model then, we had a new member of the team joining, who's a cognitive behavioral scientist. He showed that this approach is actually consistent with an ACTAR model, which has ACTAR is adaptive control of thought as a cognitive architecture, and I know it comes from Cargany Mellon and people there. Christian Lebier, I believe, he's also working on using ACTAR and on a model on cognitive, ACTAR and modeling COVID. What Matt Walsh, who's at RAND, also comes from Cargany Mellon, showed that our architecture was also similar to ACTAR, but that we're moving towards using ACTAR ourselves in these behavioral models. So I have another extra slide on this, but I'll leave it to questions if you want to go in that to detail. Okay, next slide. So I'm going to wrap up here, and I'm going to just say that now we have collected, as I said, 4 years of data, 8 waves of pre-pandemic influenza behaviors. Now we have the opportunity to, and we're starting from this fall, to collect surveys on for another 4 years on influenza vaccination and COVID-19 behaviors. And the design of this is we go back to our 1,600 flu respondents from the last flu PAS wave, but we're adding 400 new respondents who haven't seen these surveys before. And so we'll end up with 4 years of pre-pandemic and 4 years of post-pandemic, and we can really see what are the changes in risk perceptions and how perhaps the pandemic has also changed, has influenced influenza vaccination decisions. We are really interested in been in this time really sharing our data right away. Although this is shared currently, through the American Life Panel website, the past flu paths data. What we'll do is, make sure that the data is cleaned properly, and then it's not going to be embargoed for too long. Actually, we're going to reduce to the bare minimum of the embargo, and we would like to also, provide this data to the MIDAS group, and we want to make sure that everybody is aware of this. And because the idea is, we don't want just this data to just inform our agent-based models of influenza and COVID, but we would like to really make sure that this is useful to the whole community. Okay, and we have coded, we have to move fast to get the first survey out. So it's being coded right now, but these are the type of questions that we're asking on COVID, and did they vaccinate for COVID? Do they think they caught COVID? And was it a confirmed case? Which vaccination, vaccination, mask wearing, or social distancing policies affect them? And by the way, we have information of the respondents' state and geographical, perhaps even it's kind of sensitive, but the county level information. But we also have the timestamp. So the point is that it can be merged with epi data. That location. Sorry, if we could go back to the previous slide. So then we have description of risk perceptions, expectations. So, risk perception of catching COVID with and without the vaccination. We're also asking, parents, respondents who are parents, whether how much social distancing and mask wearing do they enforce on their children between 5 and 11, and whether they, whether they plan to vaccinate them, and then we're going to ask again in the spring, whether those children have been vaccinated, and to what extent they're, the mask wearing and the social distancing has been reduced. So we're trying to see if people invest in a certain portfolios of preventions, how do they do that when they have vaccination, they have mask wearing and social distancing, and when they do vaccinate, how perhaps do those other prevention measures change? And then we of course want to relate that to the prevalence at the time when the survey was fielded. So I'll wrap up here. I'm going to thank there's many people who have contributed to this. I thank, of course, NIAID for the support, and then previous members of the team and others who have worked. But here in particular, I'm listing Andy Parker and Matt Walsh, who are they're in Rand the Pittsburgh office, and they're the social scientists. Then Sarah Novak, who led the work on the deductive reasoning fixed time frame model. So that's it for me, and any questions, happy to address those.
Thanks, Raf and Pedro. That was really very, very interesting talk, and I can see any number of ways to go with that. Speaking for the MIDAS Coordination Center, we're happy to talk about taking your data and making it available to folks in whatever way you see fit. So when you're ready to do that, please get in touch. Any questions from the audience? Please raise your hand or type something into the chat or the Q&A, whatever means you like. I'll give it a second, then I'll start off with something here that.
I just want to say, I just want to say that we've been talking to different potential collaborators, and if you feel like this kind of data would be useful to your research, and if you want to have a chance of maybe even influencing what questions get into the next survey, we're completely open to talk to people. So we've been doing that, and we would like to get to talk to more people interested in how we advance behavioral modeling infectious diseases. So I know we don't have a lot of time for that right now, but if you want to send us an email, we would be happy to chat with you.
Great. So since there are no questions that anybody's thrown out, I'm going to throw the one that comes most to my mind is, you used mentioned the concept in various ways throughout this talk, talking about assumptions of rationality. And yet I would argue that that's one of those assumptions that ideally we'd have to relax a little bit, because it seems clear that there's behavior that's not rational. And that even, I think, predates COVID in many ways, because essentially when you're asking people to look at some of these things like vaccination, you're asking them to be really thinking in a Bayesian manner, which we know that people don't do very well. So can you speak to what it would take to relax assumptions of rationality in these models?
Well, with the influenza model, what we're hoping was that they're rational in the sense that they're looking at their past experiences and weighing things, and exactly as you say, in that Bayesian approach. But of course, we know so many factors, and we know, for example, other factors which affect vaccination, which are not based on adaptation. And now we know, of course, there's a lot of political, alignment with vaccination. One also big difference that we have to consider between influenza and COVID, in terms of the social network, is influences. Is that perhaps with influenza, people don't perceive it as much of a problem, and so maybe yes, there was some social network component of influence about the direct alters. But with COVID, people talk also perhaps of, they might know of a friend who caught COVID or had a bad case of COVID. So we also, in these surveys, we want to ask about, whether they've heard of 2 degree of separation information, because that might be important. So I'm not quite addressing your specific question. I'm saying various things. Yeah.
One thing that I do want to say is that I guess that there are kind of different ways to think about how people think, right? What is rationality? And one of the things we have been asking in this service is, what is their general attitude with vaccines? Are they a person who never vaccinate, or sometimes vaccinate, or do they always vaccinate? And we think that you will, when we try to model these things, you will find very heterogeneous groups of people, right? And we want to understand to what extent the individual rationality can have any influence on that, or do we really can get people to do things with mandates, right? So if people are seeing a COVID surge, did they change their vaccination attitude? Did they start wearing masks, or that doesn't simply happen in the absence of a mandate? And so this is the kind of things that the panel data can give us. And also because we hypothesize that the COVID-19 pandemic did something with their vaccination attitudes. It seems that people who are vaccinating before are more likely. People who are not and were mandated to vaccinate for COVID may not be as likely to vaccinate for flu. But so is that what's happening? So that's why we are interested in the modeling, but also in the data to keep the models in check.
Oh yeah, absolutely. I don't think it's an easy problem to get at all. And I mean, I would argue that just from a personal anecdote that I used to be resistant getting a flu vaccine because I said, well, they always got the vaccine wrong. They got the vaccine wrong, and the odds were low. And so it's arguable that that's actually not an irrational position. So I think how you define rationality is going to be really key to any of those questions. If you want to make those assumptions of rationality, I think that's sort of what you were getting at. But
yeah, and sometimes we make those assumptions to understand what they imply, right? So even in the deductive reasoning approach, the should we mitigate or suppress the next pandemic, what we are showing is that even if people are rational, if they are told that the pandemic will take forever, or that the pandemic is over, or if they are told that the cost of social distance is unbearable, even rational people would behave in that way, would relax. So that, I think that provides an argument that information is really important. We cannot just so even the deductive reasoning can shed light into things, but you have to interpret them as in a positive way, right? You have to think, well, if this is true, then this is what follows. It doesn't mean that we believe in those assumptions. It's just a mathematical result, right?
Mm-hmm.
And I'll just also add, yes, what is the true behavioral model? There's big assumptions, or and uncertainties, and let's call them those deep uncertainties, which Pedro talks about in robust decision making. So when we do the scenarios analysis, these can, it's not just the parameter values, but also the assumption, the mechanistic assumptions of behaviors that we can consider, and we should run many scenarios and see, what policies are not just optimal, but as robust to these big uncertainties. So that's where the combination of the surveys with the agent-based models together with this approach of robust decision making can come together.
Yeah, absolutely. All right, well, we're a little bit after the top of the hour, so I want to let people get on with their day, but thank you, Pedro and Rafa. It was really interesting work. I really enjoyed learning about what you're up to, and I'm looking forward to hearing more. I think we have a very clear invitation from our speakers to reach out to them and get in touch for anybody who wants to talk about any of these data or models, or to collaborate in any way. So please drop Pedro or Rafa a note, and let's see what we can build off of this. And when you're ready with your data, we'll talk about that further as well. So thanks everyone for coming. Thank you, Pedro and Rafa, and we'll see you all in January. Will be our next MIDAS webinar. So have a great holiday season, everybody.
Thank you, Harry.
All right. Thank you, everyone. Bye-bye.